As you heard, my title is Frontline Therapy. And some of the data many of us are familiar with, but I did include some updates from ASCO to make it a little bit more clinically relevant for those who are pretty familiar with some of the efficacy data with these drugs. Oops. So we saw a similar slide yesterday in Dr. Salgia's presentation. These are the currently known EGFR gene mutations. This was just published in Cancer in October. And the mutations below the green line are associated with sensitivity to EGFR therapy. And the mutations above are associated with resistance. The most common mutations are bolded. There are quite a few, and we'll revisit some of these a little bit later in the talk. So many of us have seen the oral presentations with these EGFR tyrosine kinase inhibitors versus platinum doublet chemotherapy several times at ASCO. And this is a summary of 6 trials looking at erlotinib and gefitinib versus platinum doublet chemotherapy. There's a progression-free survival benefit in all of these trials favoring the tyrosine kinase arm, but there was no overall survival benefit seen. At ASCO, there was an individual patient data analysis that was done, and this analysis found no effect whether patients had exon 19 or exon 21 mutation. There was no survival benefit when looking at all the trials together. As far as the subsequent therapy, in patients randomized to chemotherapy, 68% crossed over and received a tyrosine kinase inhibitor, and in the patients randomized to chemotherapy, 58% received in the patients randomized to the tyrosine kinase inhibitor, 58% went on to receive chemotherapy. 11% of patients in the EGFR arms did not have any subsequent therapy versus 3% in the chemotherapy arms. Though the exon 19 and 21 weren't significant in this meta-analysis, performance status and stage was significant. Stage is a little bit straightforward. The stage 4s did worse than the stage 3s included in the trial. Performance status, I think, is somewhat obvious, but also interesting at the same time. Corey Langle wrote an editorial in JCO a number of years back talking about the Lazarus effect, that we can use these tyrosine kinase inhibitors for the driver mutations and dramatically improve performance status for patients who are near bedbound. So it seems that the tyrosine kinase inhibitors can't quite get them up to the progression-free and overall survivals we see with patients who present in better shape. These findings, especially with the exon 19 and 21, were different than their previous meta-analysis, which they published in 2014. At that time, there seemed to be a favorable prognosis with the exon 19. So afatinib is the third EGFR tyrosine kinase inhibitor that we have available now that's FDA approved for frontline therapy. This is an irreversible tyrosine kinase inhibitor. It was originally developed to treat resistance to frontline tyrosine kinase inhibition. However, the performance in the setting wasn't so great, with response rates of about 7% in previously treated patients. And like gefitinib and erlotinib, compared with frontline platinum doublet chemotherapy, the afatinib has better progression-free survival. 2 large trials were presented, the LUX-3, which compared afatinib to cisplatin and pemetrexed, and the LUX-6, which compared afatinib to cisplatin and gemcitabine. And here's the progression-free survival curve for the LUX-3 comparing afatinib to cisplatin and pemetrexed. And you can see that the median was about 11 months in the afatinib arm versus 6.7 months. And these numbers are very comparable to what we see with the erlotinib and the gefitinib data in the frontline setting. The LUX trial, however, included uncommon EGFR gene mutations. So the investigators pooled the uncommon mutations from the LUX-3 trial and the LUX-6 trial, LUX-Lung-6 trial. So they had 100 uncommon mutations. I apologize if this is hard to see in the back. 75 of them were randomized to the afatinib in either of the 2 trials, and 25 into the chemotherapy. Excuse me. The investigators broke the uncommon mutations up into 3 groups, with the first group expected to be more favorable with point mutations in exons 18 through 21. The third group expected to not respond to afatinib with exon 20 insertions. And then there was a group 2, which was in the middle, which they weren't quite sure what was going to happen. On the right, you can see the waterfall plots. And though the vast majority of patients had some tumor shrinkage on the afatinib, you can see that for the groups 2 and 3s, the progression-free survivals were shorter. The best progression-free survivals were seen in the group 1s, which was about 8 months for these uncommon mutations. So the investigators also went on to look at the exon 19 versus 21 question. And again, this is pooled analysis from both the LUX-Lung-3 and the LUX-Lung-6 trial with 2 different chemotherapy backbones. And this was pretty interesting data when it came out. It was the first time we saw an overall survival benefit with one of the TKIs versus the platinum doublet chemotherapy. And that was seen in the group that had the deletion 19s. In the L858Rs, the hazard ratio was 1.25. The afatinib arm was actually a little bit underperforming to the chemo arm, but this was not statistically significant. So other investigators have looked into the exon 19 and 21 question. This is data that was published in the Lancet, and it was, I'm sorry, not, it wasn't the Lancet. British Journal of Cancer, comparing erlotinib versus bevacizumab and erlotinib, and this was a phase 2 trial that was randomized. They randomized 154 patients. And here we see the progression-free survival by mutation type, and this I think also generated quite a bit of excitement at ASCO when it was presented, and because the progression-free survival in the erlotinib plus bevacizumab arm for the exon 19 mutation was 18 months, which was a little bit much longer than we'd seen from the single agent EGFR tyrosine kinase use in the first line setting. There's also a benefit of erlotinib with the exon 21s, but the PFS wasn't as good as the PFS with the exon 19. So it'll be interesting to see the results of the investigations of Tom Sinstrom's trial, which is ongoing as we speak, comparing erlotinib to erlotinib plus bevacizumab in a phase 3 setting. So we have 3 FDA-approved frontline tyrosine kinase inhibitors. Is one easier than the other? When I started my fellowship, there were a few holdouts on the ERESA expanded access trial, and it seems to be the opinion of many people I've talked to that gefitinib is a little bit easier, possibly because it's dosed below the maximum tolerated dose that was found out in the earlier studies. But I just wanted to review a little bit about the gefitinib and afatinib toxicity. So here's the data from the gefitinib phase 4 trial, which was published last year. And to the right are the grade 3 and 4 toxicities. And it looks pretty good. You can see quite a bit of zeros for the gefitinib. There was a little bit of diarrhea, a little bit of AST, ALT elevation, pneumonia, and heart failure is the last, the one on the bottom, which is a little bit cut off. Here we have the LUX-3, LUX-Lung-3 afatinib data, and this is probably hard to see in the back. But in general, you can see here grade 3 and 4 toxicities. Diarrhea was 14%, rash 16%, stomatitis almost 9%. So a little bit, so less zeros for the afatinib compared with the cisplatin and the pemetrexed. So what if you start somebody on afatinib and they're having toxicities and you bring down the dose? This is Dr. Carbone's poster from ASCO of this past year, and they analyzed the LUX-3 trial, the impact of dose reduction. And this is, I thought, some pretty interesting stuff here. The afatinib, to start on the left, for patients who had dose reductions, those are the blue bars. and the patients that were able to be maintained on the study at 40 milligrams are in the brown bars. And for these patients who required dose reductions, their plasma levels of afatinib were actually higher. And then levels were studied again after the dose reduction was implemented. So now these patients in blue are on 30 milligrams, and they have similar plasma levels to patients who have the 40 milligram dose. And then the curve on the right shows that this dose reduction really doesn't seem to have an impact on progression-free survival, possibly because the levels are the same. But the hazard ratio is 1.25 with both the dose reduced and the 40 milligram patients overlapping. Oh, you know what? I was having some PowerPoint troubles. So at the end, I just wanted to talk briefly about the third generation agents. We'll hear more about them as we talk about mechanisms of resistance to frontline tyrosine kinase inhibitors. Dr. Ramalingan at ASCO presented his first-line data with the AZ9291 compound. Just to look at some toxicities, we have any grade 3 and 4 toxicities at the lower dose of about 33%. The response rates on the waterfall plot are clearly encouraging. This is in the frontline setting, so patients who were not exposed to erlotinib or gefitinib, and with most patients having tumor shrinkage. And the duration of response has been pretty good so far with what's been reported. And perhaps we have an update when Dr. Ramalingan comes up. But this is from ASCO June. The patients at the 80 milligram dose we have information on so far. And at 12 months out, 80% of them were still on therapy, which sounds pretty good. So that leads to a question, well, how should we incorporate these new third generation tyrosine kinase inhibitors? So there could be a strategy of starting with the first or second generation, erlotinib, gefitinib, afatinib, and then switching over to third generation upon progression if the T790 mutation is present. Or you could start with the third generation in the hopes of delaying resistance. And we don't yet have follow-up in the first line setting, but we do have a couple trials that will hopefully shed some light on this information. The FLOWER trial is with osimertinib versus gefitinib or erlotinib. It includes only exon 19 and the L858 mutations. The primary endpoint is progression-free survival. The drug is provided upon progression, so this could influence the overall survival. But hopefully we'll get a hint as to the progression-free survival, and I hope to see some impressive numbers. The second trial is with ruxolitinib, and this is a phase 2, phase 3 trial. This is more inclusive of some of those other uncommon mutations. The crossover, however, is only in the phase 2 portion, so you can argue that some of the patients on the trial may end up getting exposed to osimertinib if they didn't cross over in the phase 2. However, this is a worldwide trial. It also could be that some of these patients will have delayed access, and hopefully the data will still be important. And the primary endpoint for this trial is also progression-free survival. So in conclusion, we now have 3 EGFR tyrosine kinase inhibitors to choose from in the frontline setting. All have favorable progression-free survival compared with chemotherapy. There may be more favorable results in the exon 19 patients with afatinib, possibly bev and erlotinib combination, but further data is needed to really say that for sure, I think. Dose reductions in afatinib do not appear to compromise efficacy. And we look forward to progression-free survival data with these third generation versus first generation trials.
So questions, and while John comes up, I'm told that at the upcoming ESMO Asia meeting in 10 days, the results of the afatinib versus gefitinib trial are likely to be presented. So it'll be important and interesting to see what it shows.
So just a practical question. Okay, so what do you do now? And don't say I put them on clinical trials. you got a patient in front of you. Is there a drug of choice you're using, you know, erlotinib because you've used a lot of it? How are you approaching the patients right now with the 4 drugs available?
I've been talking to patients and trying to get a feel for what their goals are, what's the most important. Obviously, most patients want to live as long as possible, but certainly for the frail patient, I would go to gefitinib. I think it's a little bit easier, more easily tolerated. For the exon 19s, I'm moving more towards afatinib because we have that subset data. I think Tarceva is well tolerated, so if someone has a low threshold for abandoning medications because of side effects, I would maybe go for that. But I think they all work.
So in the FLORA trial, the PFS for these TKIs is about 10 months, but if you treat them until symptomatic progression, irradiate their single sites, it's 16 months. So what will happen in the trial? And besides that, right now, with first line followed by third line, the median PFS is 16 plus 10, which is 26 weeks. So if it's 14 weeks with standard treatment, and the new one, 14 months, and the new one has 16 months, but the old combination is really 26 months, not 14, the trial is going to said to be positive. But clinically, what would you do? You do the sequence. So we're going to have to be very careful about when they present that and how it actually looks, okay? Because the barrier isn't to have a longer PFS than erlotinib or gefitinib. The barrier has to have a longer PFS than the sequence.
Agreed.
So the trial may be positive, but clinically it may be totally irrelevant.
Well, and maybe that's where, some financial factors will come into play with pricing and generics, and I agree. I think that's an excellent point.
So Suresh is going to make a comment, but just one other comment. If you look at going back to gefitinib, deletion 19 always did better than LE58R, and that's the same with erlotinib. So I wouldn't make too much of your afatinib analysis. They had the same number of patients in the same sort of studies. I wouldn't be surprised if you got the same results with erlotinib and gefitinib.